Hi, my name is VK Gadi. I'm a breast medical oncologist and the Deputy Director of the University of Illinois Cancer Center, and I'm here today to kind of talk through some updates related to some major trials that were read out for HER2 positive breast cancer. And I'm with a dear friend and colleague, Tarah Ballinger. If you can introduce yourself.
Yeah, I'm Tarah Ballinger. I'm a breast oncologist and associate professor at the Indiana University Simon Comprehensive Cancer Center, and I am happy to be here.
So just a few hundred miles, but an actual time zone away, right?
Correct. Yes.
So today we're obviously going to chat a little bit about these important trials in the HER2 positive setting, but at the highest level, maybe we can start with DB09, Destiny Breast 09, which established potentially a new standard of care in the first-line therapy of patients who have HER2 positive breast cancer. Just to rehash that data at the highest level,
Yeah.
It was a positive study. It's a 3-arm study. We only have 2 of the arms published, but showing roughly a 50% improvement in the hazard ratios for the most meaningful things such as progression-free survival and the like, with a top-line number that was almost 41 months, which is remarkable, especially for somebody who's been doing this for about 25 years, to see a number like that. It's been a little while, and now we have more data kind of oozing out, as is often the case, with regards to like perceptions, patient-reported outcomes. So that's kind of where I want to focus a little bit today.
Sure.
In addition, I believe we also have some knowledge about how the placement of this therapy will happen maybe in the real world, as the NCCN guidelines have been recently updated and reflect that it is now a choice in the first line.
Yep.
So I'll stop there and just kind of ask what your thoughts are. Have you been able to use this in your own practice? And maybe we can dig into it a little bit more from there.
Yeah, I think, first of all, I think the patient-reported outcomes are going to help us make these decisions. And I think as we've started to use it in practice and see how patients are doing. When I first saw the data, just like you said, very, very impressed by the improvement in progression-free survival. My worries were about using long-term T-DXd for patients. How are they going to tolerate that? What kind of adverse effects are we going to see? But ultimately, I think this is potentially going to cure more patients with stage 4 HER2 positive disease. So I have started using it in practice, and I think patients have been doing pretty well.
Yeah, and you mentioned cure, which
Yes.
is an interesting choice of words
Yes.
always in metastatic disease.
Yes.
But it did look like there were far greater number of patients who are actually getting what we call complete responses, which maybe is a surrogate for some people actually being cured.
Yeah.
Maybe dig into that a little bit more.
Yeah, I think it was about 15% or so, and the duration of responses was longer. I don't know what it was specifically for the complete responders, but I think that's what we hope for patients with HER2 positive disease. And I think we all have many patients who have been on HER2 targeted therapy for decades without evidence of disease. And so I do think it's possible that there are some patients that are cured, if you define that as the disease is gone and doesn't impact them and they pass away of something else. So the hope for that for patients with stage 4 HER2 positive breast cancer is definitely what I have, and I don't want to miss that chance for any of my patients. So that's one of the things I'm excited about the DB09 regimen.
Yeah, we hear a lot of KOLs say this, which is the best therapy in that setting that you can get your hands on is the one we should go with, and I get it. Is there a patient profile where you see that this is obviously the NCCN is saying these two are both considered level 1, category 1 choices. Is there a specific patient profile where like, I'm definitely giving T-DXd in this scenario, or is it sort of I'm going to try this with everybody? What's been your practice?
Yeah, I mean, I think my practice is never that I'm going to do something with everybody.
Fair enough.
So I think this is a case-by-case situation, and I think that's how I've been seeing it adopted in the community. For me, just thinking about patient characteristics that will help me decide. For a patient who maybe has oligometastatic bone disease, they're ER positive, HER2 positive, that's a patient where maybe I would choose the Cleopatra regimen and then go to HP maintenance with endocrine therapy plus a CDK4/6 inhibitor like the PATINA regimen. And then we also saw a very impressive PFS in that trial as well. And that is arguably probably a more tolerable long-term maintenance regimen. So I think for those people where I think asymptomatic minimal disease burden, triple positive, probably going to be on therapy for a long time. De novo disease, so this isn't disease that occurred despite previous HER2 targeted therapy. I think those are patients where I'm still leaning more towards the Cleopatra regimen, but for almost everybody else, leaning towards the DB09 regimen.
Well, and you're an academic practitioner like me, and it's hard for me to find or remember a patient that didn't make it to a second line, where if they didn't get this drug in the first line, we have the option to give it in the next line. I'm assuming that's the same for you.
Yeah.
But you know, we know in the kind of the real world, lots more challenges for patients to get guideline concordant care. We see this huge drop off of people even getting to a second line. So, you know, thoughts on that, I guess, which is how do we educate our colleagues to say, it doesn't have to end after the first line, or what's going on in that first line where they're not even making it to a second line?
It's interesting because in DB09, in the Cleopatra arm, only about 10% of patients ever went on to get T-DXd. So I think some people have had the question, do you really need T-DXd in the front line, or do you really just need it at all? And maybe the trial doesn't answer that question. But like you mentioned, many patients in the trial never got to second line therapy, and that's also what we see from real world data, that, you know, at least a quarter of patients aren't ever getting to second line. And whether that's because by the time they progress, they're just not able to receive next line therapy, I don't know. But I think that's another reason why we should really be leaning into using our best therapies as early as possible, because it's possible that if we start with something else, the patients are never going to get to T-DXd.
Yeah, I agree. This is why I'm always cautious about what I do in my practice is very, very much not the real world. And so I have to be careful because we, in addition to these lines of therapies, we often have clinical trials and things that we can extend and extend and extend. So we take it for granted that a second line is going to happen. In the real world, at least a quarter of the patients apparently are not even getting to that line of therapy. That's unacceptably too high. So getting the right best therapy out of the gate makes a lot of sense, right? So you mentioned it briefly, but we've now starting to see some of this, what I call survivorship and tolerability data around the patient-reported outcomes, not the doctor-reported outcomes, the patient-reported outcomes. Maybe summarize that a little bit for us.
Yeah, so for DB09, they reported basically how tolerable did you find this treatment, and patients could rate that as or how bothered were you by the side effects? Not at all, a little bit, somewhat, or a lot. And what we see is that it's pretty similar across the T-DXd versus THP arm. I've only seen it reported for the first 9 cycles or so. So I would be very interested in what happens over time for these patients who are going to be on therapy for an average of several years. But it is encouraging that, you know, we're seeing very similar results there. The other thing that's been encouraging is the common side effects with T-DXd that a lot of us worry about, which at least in my practice is mostly nausea, appetite loss, this sort of blah feeling that patients get. What we see is that's not getting worse over time. If patients are having that, they have it at first, and it typically gets better as we manage it better. And then it's not worsening as they're on it long term. And for me, that was really reassuring, because when I first saw the DB09 data, that was my primary concern about using the regimen.
Yeah, I've noticed, I've looked at the data, you know, it was presented by Mo Ramawi on the podium at San Antonio. And it's interesting that many of the side effects do extinguish with time. I guess patients get comfortable, they got better anti-emetic plans, you know, the doctors are more engaged in providing palliative services after the initial blush of like, you got metastatic cancer, we got to get this under control. And you see these things stabilize. And it's remarkable, it doesn't keep deteriorating, it just sort of stays right there. But with the caveat that we've got only a handful of cycles, and we want to know what it looks like 2 years later, which we don't quite have that yet. Yeah, it doesn't look like the THP arm isn't remarkably less in many ways in terms of the overall global, is this therapy bothering you? It's actually in the ballpark, which is a little surprising when you think about THP.
And you would think that at least what I would have thought you would see is since most people are giving probably 6 cycle, the majority of us are doing 6 cycles of a taxane, I would expect then kind of immediately after that for those patients to feel better. And again, we don't have longer term, but that's not what we see.
Right. Well, you can imagine persistent neuropathy will just rob you of a lot of quality of life. Yep. As much as any nausea might. So, and at least with nausea, you can fix it. Peripheral neuropathy is tough to manage. So there's probably some subtle differences there that keep the side effect profile in THP higher than I think we acknowledge.
Yep. And I do think, a lot of us are using more and more T-DXd for many reasons in the community or in academics. And we've all gotten a lot better at managing it and also preparing patients. I'm definitely much better at preparing patients for how they're going to feel and having a plan. I use a lot of olanzapine, which works very well with the drug, I find. And even dose reductions, or some of my patients who are worried, I start them a little bit lower and go up, which again, isn't standard. It's not what was done in the trial, but I think it's definitely been helping manage people who are going to be on the drug for a long time.
Yeah, I call it vitamin O at this point. It's just part of the package. It makes a lot of sense.
I always remind them, when you look this up, I don't think you're psychotic. That's just the drug is an antipsychotic and it will help you with your nausea.
We've talked a lot about what that first line looks like, and tell me a little bit about your thoughts on maintenance, because we got hit hard with 3 reasonable options that either augment on Cleopatra or potentially replace Cleopatra. So maybe first start with PATINA. What is PATINA and what does that mean for our patients?
Yeah, so PATINA was patients with HER2 positive, ER positive disease. They had to have stable or responded to their induction therapy. And then they were randomized at that time to stay on their HER2 directed therapy and get endocrine therapy versus endocrine therapy plus palbociclib. And we saw a really impressive progression-free survival. I think it was 44 months. 44 months, which I was not expecting and was very happy to see. I'd already been doing that in practice basically, but now it's easier to get a CDK4/6 inhibitor for our patients. So I was really impressed by that data. Then we also had HER2 Climb 05. So that was patients where when they went to their maintenance HER2 targeted therapy, they were randomized to receive tucatinib or not. And again, that was a positive study, not quite as impressively, but still a positive trial. So now, in addition to DB09, we have these other 2 potential maintenance regimens that would be done after the Cleopatra regimen. And so what do we do with all of that data is really the question.
Right.
And the way I'm thinking about it, again, I think is a case-by-case basis. For most of my patients, they're probably going to get DB09 up front. If they're having trouble tolerating it for whatever reason, then I may sort of do an induction of T-DXd and then switch them to trastuzumab, pertuzumab plus maintenance, whether that's PATINA or whether that's potentially adding tucatinib if they're an ER negative patient. For patients who have low volume, asymptomatic, de novo disease, couple of bone mets, maybe I'm doing Cleopatra first and then going to PATINA,
or maybe even
like
no
that.
taxane in that type of patient.
Yeah, sure.
Just HP with endocrine therapy.
Exactly. Yeah. So I mean, I already do that for some of my patients. So that same patient population, I'm going to keep doing that, probably not escalate them all the way to T-DXd.
Right.
Yeah.
Yeah. So it's more optionality, right? How do you assess a best response?
Yeah.
Yeah. What does that mean? It's again there's no definition for that really.
No. I mean, I think if you're doing an induction, if I'm doing a taxane, then I typically just do the 6 cycles that was done in the trial. But I think if you're thinking about doing that with T-DXd, it's a little bit more complicated. There's no specific time point. So for me, it would be doing it until the patient's like, I don't want to do this anymore, and we've already optimized our antiemetics and whatever, if they're just not tolerating it. Otherwise, I think it's scanning again. Are we stable? Did we get further? And then we just kind of keep kicking the can down the road. Sort of what we do with like neoadjuvant endocrine therapy, basically. Right. I think it's a clinical judgment in that situation. Yeah,
I find I'm really careful about not putting after 6 cycles this happens or after 10. It's always going to be a conversation with the patient. You don't want to set a false expectation and then you're like, your pet is still hot.
Yes.
We need
Yes.
to keep this going. So you want to be thoughtful about it. But I do believe there's a lot of folks who could benefit from a maintenance strategy. And as much as we've seen the stabilization of toxicities and PRO reporting, it's still not as good as just being on HP. Right. So we've got to be honest about that and have those conversations with our patients.
Yep.
Last year, probably almost 6 months already have gone by, we had these two important readouts in the early stage breast cancer setting around HER2 positive disease. Namely, how could we incorporate an effective agent like T-DXd, trastuzumab deruxtecan, in the care of patients who are receiving either preoperative therapy or adjuvant therapy for those who have residual disease. So maybe at the highest level, you can fill us in on your takeaways from, let's start with first DB05, and then we can go back to DB11.
DB05 was focused on our highest risk patients, so patients who either had residual disease at the time of surgery, and they had to have started with either really high risk disease or inoperable disease, big tumors, several positive lymph nodes, et cetera. So these were our highest risk patients. And what we found is that adjuvant T-DXd outperformed adjuvant T-DM1 in terms of disease-free survival with a pretty impressive hazard ratio of about 0.5. I think it was 92% or something, 3-year invasive disease-free survival. So really impressive for this high-risk patient population, which I think is really exciting. Those are the patients that we're all worried about. And so I'm happy to see the drug move up and be effective for those patients.
So the definition of high risk is in the beholder, eye of the beholder kind of thing. In the strictest definition by the trial, I think it was, like you said, node positive, multiple node positive, inoperable, i.e. T4 disease. And in the residual disease setting after the neoadjuvant therapy, it was folks who had maybe lymph nodes that were still involved. So, very classically, I think things we would recognize as high risk.
Yep.
They actually use the term inoperable, which I look at that and go, my surgeon can get that. So I just want to throw that reminder out that, look at the stage that they were talking about, because the word inoperable is tricky. In other resource limited areas, those words might make more sense, but in the United States, they don't.
Yes.
And so just look at the stage and say, okay, did my patient meet these criteria? Yes, they did. Maybe this is an option.
Yes. They did not define inoperable as a surgeon says they can't operate on it. Yes.
Which is our definition, right? Yeah. So we have this weird scenario though now where if you get a PCR, you have this one option of HP plus minus endocrine therapy, et cetera. Then you have this, you got a lot of residual disease, high stage at diagnosis, and you get T-DXd. And then there's still patients who are TDM1 candidates. Is this confusing? Is this going to kind of make it very muddy for folks?
I mean, I think so, and kind of probably until we get used to it, similar to the adjuvant CDK4/6 kind of initially. I think that was a little bit
It's a good analogy.
muddy between abemaciclib, ribociclib, who's not going to get one at all. I think we'll get used to it as we use it, and maybe it'll be a little bit more intuitive than we think about, like, this is someone we're really, really worried about, so this is probably a T-DXd candidate. I think for now, I'm gonna follow the clinical trial protocol in terms of who's eligible for it adjuvantly, but I'm sure there will be some patients where we'll really have to think and look at the data.
It's interesting, all of these options, let's be honest, are expensive, and I don't think payers care. Like which ones we pick has been my experience. And so I wonder how much people are just gonna say, if they got anything left, we're just gonna give T-DXd, versus anybody being very nuanced and saying, this is a TDM1 patient.
Yeah.
Part of the reason why I say that is when you look at the tolerability of TDM1 versus T-DXd, I have this thing called a stick rate. The same number of cycles regardless of what they were randomized to in terms of their ability to complete the full intended number of cycles. So there's no big edge in terms of at least the patient's perspective of this is a more tolerable therapy.
Yeah.
So I can see this scenario where everybody's going to go, residual disease.
For sure.
I'm just going to give T-DXd.
Yeah.
I don't know if that's going to play out that way, but I get a sense that that might happen.
Yeah, and I mean, I can see myself doing that too for patients that are a little more borderline. I think if it's somebody with a very small amount of residual disease, still going with T-DM1, especially because I do think in DB05 there was a higher discontinuation rate due to adverse events in the T-DXd arm. We also have to worry about the ILD risk and the more frequent scans. So I think there is a little bit more burden. So I would be a little bit more cautious on the risk versus benefit for some of those patients. But I think you're right. I think we are going to see people just wanting to get T-DXd for most of their patients with residual disease.
I think TDM1 is probably getting phased out.
Yes. Yeah. In many settings. Yes.
So you brought up something really interesting, which is the more intense monitoring in terms of, we still got to get the echoes, but now we're also adding a CT scan periodically. One of the most common misperceptions I've heard just talking to colleagues is this timing of radiation therapy issue. Tell me what they did on the trial and maybe what's your take on that?
Yeah, I mean, I like in the trial that it was very pragmatic and people could do whatever other therapy they were going to need in sort of whatever way they wanted to. So radiation could be given concurrently, sequentially, same thing with endocrine therapy. And people were worried that maybe we would see more pneumonitis because of radiation. And we did not see that, which is very reassuring. So again, I like that there's sort of this mix and that we were able to be reassured about that, because that certainly was a concern and a question that comes up a lot still.
Yeah, they actually independently adjudicated every one of those findings on the scans to say this is from the radiation versus not. They looked at the radiation planning, the radiation port was analyzed and said, okay, this is this is that. They went to tremendous pains to do that, and it looked safe for all intents and purposes. So no one should really be withholding drug until radiation, et cetera. The other thing I'll say is
that's going to definitely be something I feel like getting out to the community practitioners.
Well, and the other thing lost in this is it's a global trial. We do radiation therapy with a lot more technical expertise than many parts of the world. We know exactly the parts of the lung that are going to exposed, whereas in other places it's more of a concern. So another nuance for the American practitioner that this is probably a safe way to deliver the therapies and concurrently with radiation. And then the other concurrent therapy is endocrine therapy. How have you been managing when we add for those positive patients for estrogen receptor and HER2? How are you layering in? Is there a special consideration on the timing of endocrine therapy?
No, still, I mean, the same way that I've done it with TDM1 or other therapies. At our institution, I think different institutions differ. We typically do it after radiation therapy, but still concurrently with the HER2-directed therapy. So that's what we've been doing, and I think no concerns there either.
Same. And would you still, and just to, I know we're really focused on T-DXd today, but do you use neratinib in your practice? Does that still come into play for some high-risk patients?
I do not.
Okay.
I think I've only done that a couple of times, and it's been a long while since I've done it. And the people I've done it on have been patients who have come specifically very motivated to do that and want to try it with a low threshold to stop for toxicity. But I think with all of the newer data and all of these other drugs, I'm just not sure there's a place for that anymore.
And certainly, we're cheating. We're all getting a little bit of ctDNA every now and then. Like if it's still worrisome, you're like, maybe we should think about something else. All right. Well, that's, I think, a great review. Obviously, we're still waiting for final judgment on many of these things, even though the data's out. We're clearly practicing in line with what we've seen, but there's a lot more to come out with the adjuvant setting. So for the last pivot, 3 pivots, I don't know what kind of dance that is, but I'm sure it's some sort of dance move. But for the third pivot, we've got DB11, maybe same way, review what that showed us and how you're integrating that into your practice.
So DB11, again, focused on high-risk patients, now looking at T-DXd in the neoadjuvant setting. So trial had 3 arms. One arm was 8 cycles of T-DXd. That arm closed, multifactorial reasons.
Inferior,
but looked like it was not going to beat out the standard of care arm.
PCR.
For PCR.
But interestingly, the EFS looks about the same.
Yes. So that's one arm. Another arm of ACTHP as the standard of care arm in that trial, and then the other arm being 4 cycles of T-DXd and 4 cycles of THP. Primary endpoint is PCR, and the PCR rate in the T-DXd plus THP arm, super impressive at about 67%, particularly in the HER2 positive, hormone receptor negative, it was north of 80%. So best rates that we've seen in the neoadjuvant registration trial in the HER2 positive setting. And that's the subgroup where we think PCR is telling us the patient's prognosis. We don't have, it's not powered for event-free survival, and that data is very early, but I think still very exciting result for that trial as well.
Yeah, and
makes things confusing now with all of this coming out together, but yes.
Right, but both, for the PCR rate for the hormone receptor positive group is also historically better than what we've seen as well.
Yeah.
So obviously we're in the United States again. We ain't using AC.
Yeah.
So a lot of my colleagues, friends, others are like, but I'm using TCHP. Convince me that that's not what we should be doing. Is it, like, how are you doing this now? Are you an institution that mostly uses TCHP? Yeah.
Our institution really only uses TCHP. I think some of the East Coast places still do AC THP. Yeah. And I think we can be pretty convinced from several trials that a non-anthracycline regimen is not inferior. So that's probably not the ideal control arm for me in DB11, but it's still kind of just as good of a control arm. So I don't think that makes me believe the data that in DB11 any less that they didn't use the same control arm I would have used, because I think the results of the control arm would be very similar either way.
Right.
So it's not ideal, but I don't think it's a huge issue for me in interpreting the trial.
So in your current practice, do you see for the appropriately selected patient, larger volume, nodes positive, all the things we talked about, do you see in your practice a T-DXd followed by THP or followed by TCHP, or do you bring in a few cycles of TCHP first and then go to TD? Like, how are you putting all of this together?
Yeah, I mean, I think for me, honestly, with this and DB05 all coming out, I think I need a little more time for the data to mature in DB11. Maybe for a very, very high risk patient, I might use the T-DXd up front. I think my concern is if I do T-DXd followed by THP and the patient doesn't have a PCR, what am I doing then? I don't want to go, am I going to go to T-DM1, which I know is an inferior drug, or am I going to continue more T-DXd, which is probably what I would do, but then again, did I really need to do it up front too? I don't know. So I think I'm still a little bit wary of how I'm going to actually incorporate that particular regimen into practice. So I think I'm still going to be using a lot of TCHP in the neoadjuvant space, just while we're waiting for that data to mature a little bit, acknowledging it's not powered for EFS, but I still want to see it.
I get that, and eventually we will get an EFS number, and even if it's not powered, if it looks comparable, then you know.
Yeah.
A lot of the patients who received and randomized to T-DXd got TDM1 as their quote rescue drug when they had residual disease, and if the EFS still looks good, then, and as well as the DFS and OS, all of those things, then you know it's probably okay to give TDM1.
I think we'll have to assume. I don't know.
Yeah.
I think that's going to be a tough spot for a lot of people.
I'll tell you, at our institution, we've been really trying to figure out personalized, optimized options. We're using biomarkers, treating patients who have HER2 enriched disease as assessed by, genomic classifiers as opposed to luminal type disease.
Yep.
It's interesting, the luminal type folks may actually benefit more from the T-DXd being one of the absolute therapies that they receive in the neoadjuvant setting. Whereas if you have disease that we know responds very well to HP, you might get a THP first, do a clinical assessment if it's still persistent, then get the T-DXd. So just swapping the order. Yep. But the nice thing is, the safety net is, if you get to surgery and there's still, disease, we can give T-DXd.
Use it on the back end.
Yeah,
exactly.
Back end. So it's, we're mincing words over tiny little things, but in the end of the day, I think a lot of patients are going to get the optimized therapies, and many of them, if they needed T-DXd, are probably going to find their way to it. So I don't want to be personally too prescriptive in how I tell patients, but also my colleagues in the community who come to me and say, hey, what would you do? I'm like, all three of those options sounded good to me. So you can go at it and, get where you need to get.
Yeah. And I think we're gonna, as currently developing clinical trials come out, we're going to be doing what you said, probably some kind of risk adaptive approach. I think it's hard to do that now, particularly in the community where access to those kind of assays, or how do you interpret them, or what is the right biomarker? Is it response on clinically? Is it response radiographically? And if it's radiographically, is it a breast MRI? Is it a FDG PET? What is it, and how much of a response do you need to know that you're on the right? So there's too many questions in that space. I think to be doing it regularly outside of a trial or an academic center, but that's definitely where we're going, hopefully.
So if you do the math and you get this drug in the adjuvant setting, potentially 9 months of therapy, and if you do the math in the neoadjuvant setting, it's 4 cycles. Does that influence your decisions at all, and like where you'd put in T-DXd into your practice?
I don't think that per se. I don't think the number of cycles that they're going to get, but I do think, like I mentioned, I worry about a patient that does DB11, so they get 4 cycles neoadjuvantly, they don't have a PCR, and then they get TDM1, then that feels like, did they get enough T-DXd or do they need more? So in that setting, I feel a little worried about it. But other than that,
I guess
from a toxicity standpoint,
that's where I was going. Toxicity standpoint, is there a big advantage to doing 4 sessions? Probably.
I mean, and what in DB11, that's what we saw. The rates of ILD, there was still a few cases, but it was very low. So using it in the adjuvant setting, we see more. We saw a couple deaths from ILD. So it's nice to avoid those by doing just a few cycles up front.
And even in that, just to touch on that real quickly, those cases when they were adjudicated, the couple of deaths, there were some extenuating circumstances in both of those. So, don't want to get people, we want to be appropriately worried about this toxicity, but there were some circumstances there. In the neoadjuvant setting, it's interesting how the ILD that was reported was actually delayed and reported actually when people were on the THP portion. And it was equivalent or maybe even worse with the AC arm in some cases. I think it's just a reminder that all the drugs we use are poisons and are harmful, even though we're focused on T-DXd. The standards that we use can be harmful.
And if we go looking for it, in most of our regimens, we're not scanning people, we're not looking for it. So,
well, and being a practical, pragmatic person, we look at these trials and it's appropriate for us to judge the deaths very severely that happen on study. But I've been practicing a long time, and if I'm being honest with myself, I lose patients just with standard therapies because they're sick, there's things going on, there's other comorbidities, and we have to kind of step back and go, is this really that much worse? And it's oftentimes not. The real world is actually really hard to deliver these therapies for patients for a variety of factors.
Regardless of the regimen.
Regardless,
Totally agree.
So bringing it all together, we're really optimistic for our patients, but the truth is when you look at the numbers, there are still some patients who are recurring when we do all these things. What are you thinking now? Obviously you got to get 100 patients under your belt and 6 or 7 of them are going to recur. For those patients who've seen these therapies in the adjuvant or neoadjuvant setting, what does your treatment of them look like after a recurrence happens? Are you going to recycle things? Are you going to be able to, what are the parameters around recycling? I haven't had this happen yet, so I'm just curious.
I haven't either, but definitely thought about it. And I think that is one thing people worry about. We should use our good drugs first, but I think logically some people worry about doing that. The way I will probably think about it when it does inevitably happen is the same way we've thought about the use of trastuzumab. So I think depends on the disease-free interval and how well the patient tolerated it originally. So if they tolerated it well, it's been several years, then I'm going to use T-DXd again. If they're reoccurring, 6 months later, then or tolerated it really poorly, then I'm probably not going to use it again. Then the question is, what are you using in that setting? So I think if the patient has had trastuzumab, pertuzumab, T-DXd in the curative setting, I'm probably going to like the HER2 climb regimen when they reoccur as my front line, but I think that's going to be a patient-to-patient decision too.
So possibly just a shift of lines,
Yes,
and sort
basically.
of treat it like a continuum if it's less than 6 months. But if it's
Yeah.
more than 6 months, just sort of start anew in the metastatic setting with the DB09 type regimen and go from
Probably.
there.
That's probably what I'm going to do.
Yeah.
Yes.
I, again, haven't been faced with it, but I suspect I'm also going to be in that same scenario. Obviously, first thing is, what trial do I have for this lady?
100%.
Right, that's where we're going to start. But I think all these other things. And then I still think it's important probably to biopsy the patient at recurrence, see what other mutations might be picked up. Is it still making HER2? All that stuff still matters, right?
Yep.
So, yeah,
Yep.
it'll be interesting to look at the patterns of recurrence and what's going on in those patients at that time.
Yep.
Well, Tarah, this is fun. I learned a lot. It's nice to talk to you. You're such a charming and plain-spoken person.
Thank you.
And I'm so convinced that your patients must think that about you as well. So appreciate your time today and sharing your insights and all of this. And to our audience, I hope we learned a lot. The big data readouts have come out, and now we're seeing the more nuanced data that really inform our practice. And that's where we really wanted to focus today.